Imagine you're a resident, right? It's a Friday night, you're down the ER.
Always a Friday night.
Yeah, exactly. And a patient comes in, they just jam their finger playing volleyball. So you get an x-ray, you look at the bones, and I mean, everything looks totally fine.
Right. No fractures, no obvious dislocations, just perfectly normal bones.
Exactly. So you birdie tape it, you tell them, take some ibuprofen, and you send them home. But then 3 weeks later, they come back to your clinic, and their finger is locked in this rigid, unyielding claw.
Oh, man. That is just, it's a surgical nightmare.
It really is. And you're staring at it, realizing you missed a tiny millimeter-thin tear in a web of tissue that, I mean, you couldn't even see on the film anyway.
Yeah, that scenario basically haunts every junior doctor. And, it happens because of how we're trained.
What do you mean by that?
Well, we're taught to think of orthopedic surgery as macroengineering.
Right.
We look for levers, load-bearing pillars, structural failures.
Like carpentry.
Exactly like carpentry. You see a broken femur, you put a massive titanium nail down the middle, and boom, the physics problem is solved.
Right. But the moment you step onto the dorsal aspect of the hand, the back of the hand, all that simple carpentry just completely goes out the window.
It really does. We are no longer framing a house. We're basically taking apart a Swiss watch.
Which is exactly why we're here today on this deep dive. Our mission today is to completely, totally master Module 2. The extensor mechanism.
That's right.
And look, I know exactly who is listening to this right now. You are a doctor prepping for your trauma and orthopedics exams.
Right. The DMB Orth, the MRCS, maybe the EBOT.
Yeah, and you're probably in your car right now driving home from a grueling shift or, I don't know, tackling a mountain of laundry. Your hands are full. You definitely cannot take notes.
Which means we are going to do all the heavy lifting for you here. There's no visual aids, no textbook figures to look up, no slide decks.
Purely an audio-only immersive study session.
Exactly. And because we know you can't write this down, we've built a specific mechanism into our discussion today.
Yeah, for every critical exam discriminator, every anatomical list, and every tricky multiple-choice trap, we are going to state it twice.
Right. We'll organically loop back so the knowledge actually locks into your memory before you even pull into your driveway.
Okay, so let's unpack this. To really understand this, we have to completely shift how we visualize the hand.
Yeah. Think about the palm for a second, the flexor side. That side operates on basically brute force linear mechanics.
Like a thick whip pulling through a series of circular pulleys.
Exactly. You pull the rope, the finger bends. It's simple. But the extensor side, the back of the hand, it isn't a rope.
No, it's this geometric, incredibly thin, dynamic web spread super delicately over the bones.
And balance is the entire job of that web. It takes all that gross mechanical force from the massive muscles up in your forearm, and it perfectly distributes it.
Through a central cable and two side cables, right?
Yeah, precisely. It relies on a flawless distribution of tension. If you break just one tiny strand, like our volleyball player in the ER, that tension shifts.
Then the whole finger just collapses.
Right. It collapses into one of a handful of highly predictable, highly testable deformities.
Okay, so we need to trace this anatomy from the forearm all the way down to the fingertips. Let's start right at the bottleneck.
The wrist joint.
Yeah. All these tendons have to cross from the forearm into the hand, and to stop them from bowstringing every time you extend your wrist, your body straps them down.
Right, with a thick band of tissue called the extensor retinaculum. And that strap basically creates 6 distinct tunnels.
The 6 dorsal compartments and the exam boards, they demand absolute precision on these.
Really obsess over them. We have to map them spatially. So we're going to start from the radial side, the thumb side, and walk straight across the back of the wrist to the ulnar side, the pinky side.
All right, let's walk that path. Radial side first. Tunnel number 1.
So compartment 1 sits right on the bony bump of the radial styloid.
Yeah.
And it contains 2 tendons dedicated to the thumb.
The abductor pollicis longus and the extensor pollicis brevis.
Yeah, the APL and the EPB. And if you're looking for the clinical tie-in here, this tight tunnel is the exact site of de Quervain's tenosynovitis.
Right. When those 2 tendons get inflamed, they swell right against the room of compartment 1.
Exactly. So then moving ulnarly, we hit compartment 2. This tunnel holds your primary wrist extensors.
That's the extensor carpi radialis longus and the extensor carpi radialis brevis, the ECRL and ECRB.
You got it.
I actually find it helpful to think of the first 2 compartments by their targets. Like compartment 1 targets the base of the thumb, compartment 2 targets the base of the hand to lift the whole wrist.
That's a great way to think about it. Now, compartment 3 is where the anatomy takes a bit of a strange turn.
Yeah, compartment 3 holds just one single tendon, right?
Mm-hmm.
The extensor pollicis longus, or EPL.
Right. But it doesn't just run straight down the wrist. The radius bone has this distinct raised bump on its dorsal surface.
Lister's tubercle.
Exactly. Lister's tubercle. The EPL tendon exits its tunnel and sharply hooks right around this bony bump, basically using it as a biological pulley.
Let's actually pause and look at the why here. I mean, from an evolutionary perspective, why on earth would a tendon take a sharp detour around a piece of bone?
Right, instead of taking the shortest path.
Yeah, it seems like bad engineering to put a tendon under that kind of massive friction.
It seems like it, but it's actually brilliant engineering.
Mm.
By hooking around Lister's tubercle, the EPL changes its line of pull by about 45 degrees.
Oh, wow.
Yeah. So instead of just pulling the thumb up alongside the index finger, this new angle allows the EPR to pull the thumb out and away from the palm.
Like the classic hitchhiker's thumb.
Exactly. That specialized vector is what gives humans the ability to open our hands incredibly wide to grasp large tools. It's a massive evolutionary advantage.
Even if it creates a friction point.
Yeah, even with the friction. And of course, examiners love that friction point.
Oh, they definitely do. They rarely just ask what is in compartment 3. They want the spatial geography. They'll ask something like, which tendons flank Lister's tubercle?
Right. So physically, Lister's tubercle sits right on the ridge between compartment 2 and compartment 3.
Okay.
So that means it is flanked by the ECRB tendon from compartment 2 on its radial side and the EPL tendon from compartment 3 on its ulnar side.
Got it. The EPL uses that bump as a sharp pivot, okay? Then we step over into compartment 4.
Yeah, this is the crowded one.
It really is. It contains the main extensor tendons for your fingers, the extensor digitorum communis, or EDC.
Right, and it also contains an extra dedicated extensor for your index finger, the extensor indicis proprius, or EIP.
But I really want to zero in on the third structure in this tunnel because this is a massive exam trap. Why do examiners completely obsess over the fourth compartment?
They obsess over it because the fourth compartment is the only dorsal wrist tunnel that contains a nerve.
Okay, that's huge.
Yeah. Nestled right on the floor of that compartment, deep to the tendons, is the terminal branch of the posterior interosseous nerve, the PN.
Wait, hold on. If the PN is running through a tendon tunnel at the wrist, are we worried about the patient losing motor function if that nerve gets compressed?
Ah, that's a crucial distinction to make. By the time the PN reaches the fourth compartment down at the wrist, it has completely exhausted all of its motor fibers.
Oh, I see. It's already innervated the forearm muscles higher up.
Exactly. Down here in the wrist, it is purely a sensory nerve. Specifically, it provides proprioception to the dorsal wrist capsule.
So it's basically acting as a biological sensor.
Yeah, constantly feeding your brain data on exactly where your wrist is in three-dimensional space. And examiners love to ask, which tendon shares a compartment with the posterior interosseous nerve?
And the answer you must know is the EDC and the EIP in compartment 4.
Spot on. We have 2 more tunnels to go to finish crossing the wrist.
Right. Let's hit compartment 5.
So compartment 5 sits right over the radial lar joint, and it holds the extensor digiti minimi, the EDM.
Which is the independent extensor just for the little finger.
Exactly. And finally, way over on the far ulnar border of the wrist, compartment 6 holds the extensor carpi ulnaris, the ECU.
Okay, I am driving. I can't look at a textbook. Let me paint this picture in my head to make sure I've got it, and let's repeat this twice for the listener.
Let's lock it in. Walk me across the wrist one more time.
Okay, compartment 1 is the abductor pollicis longus, APL, and extensor pollicis brevis, EPB.
Right.
Compartment 2 is the radial wrist extensors, ECRL and ECRB.
Yes.
Compartment 3 is the extensor pollicis lambus, the EPL, hooking around Lister's tubercle.
Perfect.
Compartment 4 is the EDC, the EIP, plus that terminal P.
Exactly. The only nerve.
Compartment 5 is the EDM for the pinky. And compartment 6 is the ECU.
That's the first time. Let's do it once more quickly for the repetition.
You got it. Compartment 1, APL and EPB. Compartment 2, ECRL and ECRB.
Compartment 3.
Compartment 4, EDC, EIP, and the pippin.
Compartment 5, EDM. And compartment 6, ECU.
And let me synthesize those exam traps to repeat them twice as well. The nerve in the fourth compartment is the pinnae, sitting with the EDC and EIP.
Right.
And let me say it again. The nerve in the fourth compartment is the terminal pinnae, sharing space with the EDC and EIP.
Excellent.
And the other Trapp-Lister's tubercle sits right between compartments 2 and 3, meaning it's flanked by the ECR tendons on one side and the EPL on the other.
And again, Lister's tubercle is between compartments 2 and 3, flanked by the ECR tendons radially and the EPL ulnarly.
Awesome.
If you only remember one thing from this anatomy, 6 compartments, 1 is APL and EPB, 2 is the radial wrist extensors, 3 is the EPL wrapping around Lister's tubercle, 4 is the EDC, EIP plus the pennon, 5 is the EDM, and 6 is the ECU.
Okay, so we have survived the bottleneck at the wrist, but as these thick, round cables cross over the big knuckles, the metacarpophalangeal joints, the architecture completely transforms.
Yeah, they stop being round cables entirely and flatten out into the extensor hood.
Yeah.
This is the web we were talking about earlier.
Right. Visualizing this transition is totally critical.
It really is. As the tendon flattens, it divides its forces. You need to picture 3 main tracks running down the back of the finger and 2 critical tethers holding those tracks in their lanes.
Let's look at the tracks first. The middle track is called the central slip, right?
Yes.
Yeah.
It runs straight down the dead center of the finger, and it inserts into the dorsal base of the middle phalanx.
And its only job is to extend the middle joint of your finger, the proximal interphalangeal joint, or PIP joint.
Exactly. So the central slip handles the middle joint.
Right. So then what handles the tip of the finger?
Well, as the central slip goes straight, the extensor mechanism splits off 2 side tracks called the lateral bands.
Ah, okay.
These bands sweep down the sides of the finger. They completely bypass the PIP joint, join back together over the middle phalanx to form one terminal tendon, and then they insert into the base of the distal phalanx.
Meaning their job is to extend the very tip of your finger, the distal interphalangeal joint, or DIP joint. Spot on. You know, I always wondered why human fingers evolved this way. Like, why not just have one cable that attaches to the middle bone and another completely separate cable that attaches to the tip?
Yeah, why split them from a common origin?
Right. It seems overly complicated.
Well, it's all about the fluidity of grasping. Think about it. If you had completely separate muscles and tendons for every single finger joint, you would need a brain the size of a beach ball to coordinate a simple grasping motion.
Oh, that makes so much sense.
By splitting one massive tendon into a central slip for the middle joint and lateral bands for the tip joint, the hand biomechanically links the extension and flexion of those joints.
So as your middle joint bends, the geometry of the hood physically shifts.
Exactly, allowing the tip to naturally curl with it. It basically turns a super complex neurological task into a passive mechanical one.
Wow. But those lateral bands running down the sides of the finger, I mean, they can't just float freely.
No, definitely not.
As the finger bends and straightens, what stops them from slipping too far down toward the palm or snapping too far up toward the ceiling?
This is where those 2 tethers come in. We have a tether on top and a tether underneath.
Okay, let's start on top.
Dorsally, on the top of the finger, we have the triangular ligament. It sits like a bridge between the 2 lateral bands and stops them from sliding down too far towards the palm.
And underneath.
Volarly, on the underside of the finger, we have the transverse retinacular ligament. This ligament anchors the lateral bands down, stopping them from riding up too high toward the top of the knuckle.
Here is where it gets really interesting. This brings us to the biomechanical core of the entire hand, the seesaw analogy.
Yes. This geometry is entirely dependent on the axis of rotation of that middle PIP joint.
Right, the PIP joint is basically the fulcrum of a seesaw.
Exactly. What's fascinating here is if you look closely at the lateral bands, they normally sit just a dorsal to the midline axis of that PIP joint, but the margins are incredibly slim.
Millimeters, really.
Literally millimeters. And the same anatomical structures, these lateral bands, can cause 2 entirely distinct opposite deformities just by slipping a tiny bit onto the wrong side of that joint axis.
Okay, let's map that out. What happens if they drop?
If those lateral bands drop below the horizontal axis of the PIP joint, meaning they fall volar toward the palm, they undergo a complete mechanical inversion.
Wait, meaning what?
Instead of helping to extend the finger, they suddenly become flexors of the PIP joint. And that downward shift is what causes a boutonnière deformity.
Man, that is wild. But if the seesaw tips the other way...
If the lateral bands right above the axis, meaning they shift dorsally, higher on the back of the finger, they exert a massive upward pull, throwing the PIP joint into severe hyperextension.
And that upward shift causes a swan-neck deformity.
Exactly. 2 opposite mechanical disasters, dictated entirely by which side of the axis those bands fall on.
Let me summarize this web so the listener can lock it in. We need to repeat this twice.
So far.
The central slip goes straight to the base of the middle phalanx to extend the PIP joint. The lateral bands bypass the middle, go to the base of the distal phalanx and extend the DIP joint.
Right.
The triangular ligament sits on top to stop the bands dropping volar. The transverse retinacular ligament sits underneath to stop the bands subluxing dorsal.
Let's do that one more time. Central slip goes to middle phalanx for the PIP. Lateral bands go to distal phalanx for the DIP.
Triangular ligament on top stops volar drop. Transverse retinacular ligament underneath stops dorsal subluxation.
Perfect. And tying it to the deformities, we have to repeat this twice because it's the key to everything. Volar displacement of the lateral bands equals a boutonnière. Dorsal displacement of the lateral bands equals a swan-neck.
Once more, volar displacement equals boutonnière. Dorsal displacement equals swan-neck.
Yes. If you only remember one thing from this anatomy segment, the central slip goes to the middle phalanx to extend the PIP, the lateral bands go to the distal phalanx to extend the DIP. Bands dropping volar equal boutonnière, bands riding dorsal equals swan-neck.
All right, now that we have built this pristine, perfectly balanced web, it is time to start breaking it.
Let's break it.
Let's look really closely at that first mechanical failure, the boutonnière deformity. This is the collapse that happens when your central cable snaps.
Right. The primary lesion here is a rupture of the central slip. Imagine that central cable snapping. You have suddenly lost the primary structure holding the middle of the finger straight.
Without it, the PIP joint just immediately drops into a flexed posture.
But the deformity doesn't stop there. Because of the seesaw effect we just discussed, the entire web gets dragged into the pathology.
Yeah, the collapse basically triggers a cascade.
It does. When the PIP joint flexes, the whole extensor hood slides forward. The lateral bands lose their dorsal tension, they stretch out that triangular ligament, and they slide sideways, falling volar to the axis of the PIP joint.
And suddenly, they're acting as flexors, making the middle joint bend even worse.
Exactly. But here is the critical part. Because they have slipped downward and forward, their line of pull on the very tip of the finger becomes incredibly tight.
Oh, so they overpull the tip.
They severely overpull it, so the distal joint gets cranked backward.
So the posture you see in the clinic is a flexed PIP joint and a rigidly hyperextended DIP joint.
That's the exact clinical picture.
Yeah.
And if you look at the anatomy, the head of the proximal phalanx actually bursts through the gap in the torn extensor hood.
Like the bone physically pokes through the torn fibers?
Literally. It looks viscerally exactly like a button poking through a buttonhole. And fun fact, boutonnière is just French for buttonhole.
Oh, wow. It's a perfect visual descriptor. PIP flexed, DIP hyperextended, with the bone acting as the button.
Now, we absolutely must talk about a massive clinical trap that shows up in exam vignettes all the time.
Yeah.
Let's go back to your opening hook, the classic volleyball injury.
Right, so the candidate reads a prompt. A patient jams their finger catching a ball. They suffer a volar dislocation of the PIP joint. The ER doc reduces it, gets a post-reduction x-ray that looks beautiful, and sends them home.
Yep.
3 weeks later, they come to your clinic and they cannot actively extend their PIP joint. Why?
Well, a volar dislocation of the PIP joint is functionally totally distinct from a dorsal one. When the middle phalanx dislocates volarly toward the palm, the head of the proximal phalanx is driven violently backward through the extensor mechanism.
Think of the physics there. The bone acts like a blunt spear, ripping right through the dorsal tissue.
Exactly. This mechanism classically ruptures the central slip right at its insertion on the middle phalanx.
Which means a volar PIP dislocation is essentially a guaranteed boutonnière deformity waiting to happen if you don't splint it properly.
Precisely. And that leads to the management sequence trap. Let's say you see a patient with a chronic boutonnière deformity. It's been there for 6 months.
The finger is stuck bent at the PIP.
Right. The examiner asks you for the next step in surgical management, and the multiple choice options are just this menu of complex tendon reconstructions.
Do not take the bait. You cannot just sew the tendon back together.
No, if you try to correct a chronic boutonnière with a tendon procedure straight away, you will fail. Over those 6 months, the joint capsule has scarred down. The collateral ligaments have contracted. The joint is physically, mechanically stiff.
So what's the first step?
You must regain full, passive PIP joint extension first. You send them for intensive hand therapy, you use dynamic splinting, or you perform a surgical capsular release. You have to be able to effortlessly bend the joint straight with your own hands before you do any tendon work.
Because if the joint doesn't move passively, your beautiful tendon repair will just stretch out and fail against the resistance of the stiff joint.
Exactly. It's a guaranteed failure.
Okay, let me synthesize this for the listener driving right now. We'll repeat the core facts twice. First, the posture. Boutonnière is a flexed PIP joint and a hyperextended DIP joint.
Posture again. Flexed PIP, hyperextended DIP.
Second, the trauma trap. A volar PIP dislocation classically ruptures the central slip.
Trauma trap again.
Hmm.
Volar PIP dislocation ruptures the central slip.
Third, the surgical trap. In a chronic case, you must regain passive joint extension before you attempt any tendon reconstruction.
Surgical trap again. Restore passive extension first. Tendon reconstruction is always second. Examiners love that one.
If you only remember one thing about boutonnière, it is a central slip rupture causing a flexed PIP and a hyperextended DIP. In chronic cases, always restore passive extension before touching the tendon.
Spot on. So let's move to the exact opposite mechanical failure, the swan-neck deformity. This is the collapse when our seesaw tips backward.
The posture here is literally the mirror image of a boutonnière.
Right. The middle joint, the PIP, is hyperextended, arching backward toward the ceiling. The tip joint, the DIP, is flexed, dropping downward.
It physically arches like the graceful, curving neck of a swan.
Exactly. Now, boutonnière starts with a torn dorsal cable, the central slip, but swan neck usually starts with a failure on the underside of the finger, the volar side.
Let's unpack the biomechanics.
The biomechanical driver here is that the volar restraint at the PIP joint becomes lax or incompetent. That restraint is a thick cartilaginous structure called the volar plate.
The volar plate acts exactly like a check rein on a horse or a doorstop. It physically stops your finger from bending backward past 0 degrees.
Right. When that check rein is stretched out, whether from rheumatoid arthritis destroying the joint or a traumatic hyperextension injury or even a connective tissue disease like Ehlers-Danlos, the PIP joint is allowed to hyperextend.
And once the joint drops backward into hyperextension, look at what happens to our extensor web.
The lateral bands slide dorsally. They ride up high above the axis of rotation.
And now all the extensor muscle force from the forearm is concentrated on pulling the PIP joint backward.
Because all the force is trapped at the middle joint, the tip of the finger is starved of extension, causing the DIP to drop into flexion.
Now wait a second. I'm going to push back here. If the volar plate is what stops the finger from bending backward, why are we blaming the lateral bands for the swan neck deformity? Aren't the lateral bands just innocent bystanders that get shifted out of place?
That is an excellent point of physiological pushback.
Yeah.
You are right that the volar plate failure is the initiator, but the lateral bands are the executioners.
Oh, I like that.
Yeah. Once the volar plate fails and the joint hyperextends slightly, the lateral bands shift dorsally. Once they shift, their massive mechanical advantage physically locks the joint into that hyperextended posture. They go from being innocent bystanders to the active deforming force.
Okay, this is a perfect time to address a really confusing issue in the literature. One of the primary source texts for T&O exams has an incredibly tricky, almost muddled question about the primary cause of a swan neck, and it blames the transverse retinacular ligament.
Oh yes, bad test questions can really ruin a good exam strategy.
If I'm sitting in the exam hall, what is the hard truth?
Let's provide clean, examinable facts. The source text suggests the primary cause is the attenuation of the transverse retinacular ligament. We know the transverse retinacular ligament normally tethers the lateral bands underneath the finger, but its isolated failure isn't the primary driver.
Right.
The true primary mechanism of a swan neck is PIP hyperextension, resulting from an incompetent volar plate.
Yeah.
That laxity lets the lateral bands slip dorsal. The loss of the transverse retinacular ligament contributes to the pathology, certainly, but volar plate laxity is the key through line that initiates the entire cascade. Focus on volar plate laxity as the trigger.
So what else can trigger this cascade? Because examiners love a good, which of the following is not a cause question.
Yeah, they do. So the list of true causes for swan neck includes mallet finger, which drops the tip and throws off the balance, volar plate laxity, as we just discussed, intrinsic muscle tightness, which is incredibly common in the rheumatoid hand, and FDS insufficiency.
Let's briefly explain FDS insufficiency for a second. The flexor digitorum superficialis is a muscle that bends the middle joint toward the palm. If that muscle is cut or weak, you lose the downward tone on the PIP joint, which allows the extensor pull to win the tug of war and hyperextend the joint.
Exactly. You lose the volar balance. So those are the causes. But the absolute classic not answer. The exam will ask, which of these is not a cause of swan neck deformity? And the answer they want is central slip rupture.
Because central slip rupture causes a boutonnière. It's the exact opposite mechanism. You completely lose PIP extension in a boutonnière, whereas a swan neck is defined by excessive, unyielding PIP extension.
I mean, it sounds incredibly obvious when we reason through it like this, but when you are on hour 3 of a written exam and staring at a screen, Your tired brain can absolutely transpose them. Let's reinforce it.
Listener, hear this twice. Swan-neck posture, PIP hyperextended, DIP flexed.
Swan-neck posture. PIP hyperextended, DIP flexed.
The primary driver. Volar plate laxity, allowing the lateral bands to ride dorsal.
The true mechanism. Volar plate laxity, letting lateral bands go dorsal.
The trap answer. Central slip rupture is never a cause of a swan neck.
Central slip rupture causes boutonnière, never swan neck.
If you only remember one thing from this segment, swan neck is PIP hyperextended, DIP flexed, driven by a lax volar plate with dorsal lateral bands, and central slip rupture is never a cause.
Boom. Nailed it.
Okay, we have covered the middle of the finger. Now let's look at failures at the absolute tip and the absolute base. Segment 5, mallet finger and the sagittal band, also known as boxer's knuckle. Let's start at the tip.
Right, mallet finger is a disruption of the terminal extensor tendon at the DIT joint. You are tucking in a bedsheet, or you catch a basketball directly on the tip of an outstretched finger.
And the terminal tendon either snaps mid-substance or it avulses a tiny piece of bone right off the distal phalanx.
Exactly. And the result is that the tip of the finger droops into flexion. The patient cannot actively straighten the very tip of their finger. It physically looks like a drooping mallet.
But as you mentioned briefly during our swan neck discussion, leaving a mallet finger untreated isn't just about accepting a slightly bent fingertip. It actually throws off the entire extensor web.
It creates a massive shift in tension.
Yeah.
Think of the extensor mechanism like a perfectly taut rubber band running from the forearm all the way to the fingertip. If the tendon snaps at the tip, it isn't pulling on the distal phalanx anymore.
So all of that tension has to go somewhere.
Right. All of that extensor muscle force retracts proximally and concentrates its unchecked pull on the central slip, the middle joint. Over time, this constant, unopposed upward pull stretches out the volar plate.
The PIP joint begins to hyperextend, and you develop a secondary swan neck deformity purely because of an untreated injury at the tip.
That is the cascade of the web. Everything is connected.
Wow. Now let's go all the way back up to the big knuckle, the MCP joint. Boxer's knuckle.
We need to introduce a new supporting structure here, the sagittal bands. At the level of the big knuckle, the extensor tendon doesn't have a bony tunnel. It is kept dead center on top of the metacarpal head by a fibrous lasso called the sagittal band.
It straddles the MCP joint exactly like reins on a horse, pulling equally on both sides.
Exactly. But if you strike something hard with a clenched fist, like a boxer punching a heavy bag or someone hitting a wall in frustration, you can rupture one side of that lasso.
And the exam fact to know here is that it is almost always the radial sagittal band that ruptures, most commonly in the middle finger. Why the radial side?
Because of the natural biomechanics of a punch. When your hand is in a fist, your fingers naturally deviate slightly toward the ulnar side. When the impact occurs, the force violently drives the extensor tendon ulnarly, which places maximum tearing stress on the radial-sided sagittal band.
And when the radial band tears, the extensor tendon subluxes or slides off the top of the knuckle and falls into the valley between the knuckles on the ulnar side.
Yeah. So imagine the patient sitting in front of you. If we connect this to the bigger picture, how do you diagnose this biomechanical failure purely by examination without an MRI?
What's the clinical sign?
The clinical sign is perfectly logical if you think of a slipped bicycle chain. When the patient makes a fist, the tendon slides off the high point of the knuckle into the ulnar valley. Because it is sitting deep in the valley, it has lost its mechanical advantage.
The line of pull is now below the axis of rotation of the joint.
Exactly. Therefore, the patient cannot actively initiate MCP joint extension. They try to open their hand, and that finger stays curled. They cannot start the pedal stroke.
But, and this is the magic trick, if you take their curled finger and passively lift it up perfectly straight, and then let go.
They can hold it there. Because by lifting the finger straight, you have manually pulled the tendon out of the valley and placed it back on top of the knuckle where it belongs. You have put the bicycle chain back on the gear.
Once it is physically relocated on the high point of the joint, it regains its mechanical advantage and can hold the position, cannot initiate extension, but can maintain it.
That is the absolute hallmark clinical sign of a sagittal band rupture.
And how do we manage it?
Acutely, if you catch it within the first few weeks, you splint the MCP joint in extension for 4 to 6 weeks. This keeps the tendon centered on top of the knuckle and lets the torn radial band heal. If it is a chronic injury or conservative management fails, you have to take them to the operating room and reconstruct it surgically.
Let me summarize this for the listener so we get our double reps in. Mallet posture. a drooping terminal tendon at the DIP.
Repeating. Mallet is a drooping terminal tendon at the DIP.
Boxer's knuckle, a sagittal band rupture with ulnar subluxation of the tendon.
Boxer's knuckle. Sagittal band tear, ulnar subluxation.
The clinical sign for boxers. The patient cannot initiate MCP extension, but can maintain it if placed passively.
Clinical sign. Cannot initiate, but can maintain extension.
Acute treatment is splinting. Chronic is reconstruction.
Acute equals splint. Chronic equals reconstruct.
If you only remember one thing from this segment, mallet is the terminal tendon drooping at the DIP. Sagittal band rupture is boxer's knuckle, where the tendon slips ulnarly. They can't start MCP extension, but can hold it if placed there. Acute means splint. Chronic means reconstruct.
Awesome.
Okay, we're about halfway through the deep dive. You're driving, your brain is absorbing a ton of anatomy, so let's pause and lock this foundation in with a mid-episode recap before we move on to the tricky bedside tests.
Let's synthesize the journey so far. We crossed the wrist through 6 compartments. 1 is APL and EPB. 2 is ECRL and ECRB. 3 is the EPL hooking around Lister's tubercle. 4 is the EDC, the EIT, and importantly, the sensory PI. 5 is the EDM. 6 is the ECU.
We followed the pendons to the finger where they form the hood. The central slip goes to the middle phalanx for the PIP joint. The lateral bands go to the distal phalanx for the DIP joint.
We looked at the collapses. Boutonnière is a flexed PIP and hyperextended DIP, caused by a ruptured central slip. Swan-neck is a hyperextended PIP and flexed DIP, driven by volar plate laxity, and is never caused by a central slip tear.
At the tip, a terminal tendon tear causes a drooping mallet finger.
And at the base, a radial sagittal band tear causes boxer's knuckle, where the tendon slips into the ulnar valley, meaning the patient cannot initiate extension but can hold it.
Take a breath. Now we transition from anatomy into pure clinical examination. 3 eponymous tests that are constantly swapped in multiple choice questions to confuse you. Elson, Boys, and Bouvier.
We need to categorize these immediately so you don't get lost in the names. 2 of them test for central slip injuries. 1 of them has absolutely nothing to do with the central slip. Let's start with the gold standard test for catching an acute central slip injury. Elson's test.
Picture the patient sitting in the ER. They just jammed their finger playing sports. How do you physically perform Elson's test?
You have the patient rest their hand flat on a table, and you bend their injured PIP joint down 90 degrees over the edge of the table. Then you place your finger on their middle phalanx, and you ask the patient to try and straighten their finger against your resistance.
Why specifically 90 degrees? What is the biomechanical magic of that angle?
It is brilliant anatomy. At 90 degrees of PIP flexion, the lateral bands naturally slide forward and drop volarly. At this specific angle, they are completely slackened and taken out of the equation for DIP extension.
Okay, so they're slack.
Right. If the central slip is healthy and intact, the patient will push strongly against your finger. Because the lateral bands are slack, the tip of their finger, the DIP joint, will remain soft, floppy, and relaxed.
But what if the central slip is ruptured? What happens when they try to push against your finger?
If the central slip is torn, all the extensor force coming from the forearm reaches the knuckle and has nowhere to go. It bypasses the middle phalanx entirely. The body desperately recruits the lateral bands to try and force the joint straight.
This massive surge of misdirected tension travels rapidly down the lateral bands, straight to the tip of the finger.
Exactly. The positive sign for Elson's test is weak PIP extension against your finger. PLUS, a rigid, tightly hyperextended DIP joint.
I have actually felt this in clinic. You tap the tip of their finger while they are pushing against you, and instead of being floppy, it feels like a solid rod of wood. It is completely unyielding.
That wood-like rigidity at the DIP is the hallmark. Weak PIP extension, rigid hyperextended DIP. That is Elson's test. And it catches the acute central slip tear before the finger collapses into a chronic boutonnière.
Now, what happens if you miss it and they come back months later?
That is when you use Boy's test.
Boy's test is for the late chronic central slip injury. Let's say the patient comes to you 3 months after the trauma.
Over those 3 months, the torn central slip has retracted, scarred down, and healed with dense, unyielding fibrous tissue. The lateral bands are now firmly glued in their displaced volar position. To perform Boy's test, you passively hold the patient's PIP joint perfectly straight. Then you ask the patient to actively flex the tip of their finger, the DIP joint.
If my finger is healthy, that's easy. I'm doing it right now. I hold my middle joint straight, and I can easily bend the tip.
Because your healthy lateral bands can smoothly glide forward to allow the tip to bend. But in a late central slip injury, it is difficult or entirely impossible.
Because the extensor hood is scarred and adherent proximally.
Right. The lateral bands are under immense tension and cannot glide forward. The positive sign for Boy's test is difficult or impossible DIP flexion when the PIP is held extended.
So what does this all mean? How do we keep them straight? Elson is for the early acute tear. Boy's is for the late adherent scarred tear. That leaves the odd one out. Bouvier's test.
Bouvier's test has nothing to do with central slip tears. It is used to evaluate clawed hands, typically resulting from an ulnar nerve palsy. In a severe claw hand, the intrinsic muscles are paralyzed. The large MCP joint hyperextends awkwardly, and the PIP joint drops into a tight flexion claw.
And Bouvier's test determines if the extensor mechanism at the PIP joint is still structurally functional, even though the nerd is dead.
Exactly.
How does blocking the big knuckle prove that?
You take your hand, and you physically block the patient's MCP joint from hyperextending. You push their big knuckle down flat to neutral. By blocking the MCP joint, you reroute the extensor force distally. If the patient can then spontaneously straighten their clawed PIP joints, the test is positive.
It proves the extensor hood itself is intact, and a simple surgical procedure to permanently block MCP hyperextension and anti-claw procedure will successfully restore their hand function.
That's it, exactly.
Let me synthesize these eponymous tests so they don't blend together in the exam hall. We'll do it twice. Elson's test. Flex PIP 90 degrees, extend against resistance. A rigid, hyperextended DIP means acute central slip rupture.
Repeating. Elson's test, flex PIP 90 degrees. Rigid DIP means acute central slip.
Boy's test. Hold PIP straight, patient tries to flex DIP. Impossible flexion means a late adherent central slip.
Boy's test. Impossible DIP flexion means a late adherent central slip.
Bouvier's test. Block MCP hyperextension to see if the IPs straighten. Used for claw hands, not central slips.
Bouvier's test. Block MCP to evaluate the claw hand. Nothing to do with central slip.
If you only remember one thing from this segment, Elson's test, which gives a rigid, hyperextended DIP against resistance, catches the acute central slip. Boy's catches the late adherent one. Bouvier is for the claw hand, not the central slip.
Perfectly stated.
And just to be completely ironclad on this, we are going to do a rapid mid-episode recap to you right now.
Plain and simple. Elson is acute central slip. Boy's is late adherent central slip. Bouvier is the anti-claw test.
Brilliant. Now we shift our focus from anatomy and bedside tests to two huge clinical trauma scenarios that are basically guaranteed to show up in your surgical exam. We are looking at EPL rupture and the Pulvertaft weave. Let's set the clinical vignette.
Okay. A 55-year-old patient trips and falls on an outstretched hand. They suffer a distal radius fracture, a broken wrist. The ER doctor looks at the x-ray, and it is a perfectly non-displaced fracture. The anatomy is beautifully aligned.
The doctor puts them in a cast for 6 weeks. They come out of the cast, the bone is healed, everything looks great.
Right. But then, 2 weeks later, they're at home pouring a kettle of water. They feel a sudden painless pop at the back of their wrist, and instantly they cannot lift their thumb off the kettle handle.
They have completely lost active thumb extension. The diagnosis is an extensor pollicis longus, or EPL, rupture.
And here is the major exam trap fact you must internalize. An EPL rupture is statistically more common after non-displaced distal radius fractures than after severely displaced mangled ones.
I remember learning this and thinking it felt completely backward. Why would a fracture that hasn't even moved cause a thick tendon to snap weeks later? It makes intuitive sense that a jagged, displaced bone edge would cut a tendon, but a perfectly aligned bone.
It comes back to the anatomy of the third dorsal compartment we discussed earlier. The EPL tendon runs tightly through that closed tunnel and hooks around Lister's tubercle. It has a very specific vascular watershed zone right at that pullian area with a fragile, tenuous blood supply.
Okay, so it's vulnerable.
Very. When a wrist fracture is violently displaced, the thick extensor retinaculum is often ripped open, naturally releasing the pressure. But in a perfectly aligned, non-displaced fracture, the third compartment tunnel remains completely intact.
So the fracture bleeds into a closed space. It's essentially a localized compartment syndrome.
Exactly. Fracture hematoma and swelling build up inside that tight, unyielding tunnel. The pressure inside the third compartment exceeds the capillary perfusion pressure. It cuts off the microcirculation to the tendon.
The tendon becomes ischemic and begins to die silently inside the intact tunnel.
Then, over weeks, as the patient moves their thumb and the dead tendon rubs against the bone, it undergoes severe attritional wear until it finally frays and snaps under normal daily use, like pouring a kettle.
So we have a snapped EPL. We diagnose it. We take the patient to the operating theater. But you can't just take a needle and suture the two torn ends back together. Why not?
Because of that attritional wear, the tendon hasn't been cut cleanly with a sharp knife. It is frayed and degenerated like an old rotten piece of rope over a distance of several centimeters.
There's nothing clean to sew.
Right. There's simply nothing healthy to stitch together. If you try to pull the ends together, the stitches would just pull right through the diseased, mushy tissue. The gap is too large.
So the surgical solution is an EIP to EPL tendon transfer.
We have to borrow a spare tendon to act as an engine. Remember compartment 4? The index finger has two extensor tendons, the communal EDC and the dedicated EIP.
And the index finger can function perfectly well with just the EDC.
Exactly. So we make an incision, cut the EIP tendon near the knuckle, pull it all the way back up to the wrist, and reroute it over toward the thumb to permanently take over the job of the dead EPL.
But connecting a donor tendon to a recipient stump isn't like tying your shoelaces. You don't just tie a square knot. You use a highly specific surgical connection called a Pulvertaft weave.
Guy Pulvertaft was an incredible British hand surgeon, and the weave named after him is the gold standard for tendon transfers. The weave involves taking the donor tendon, the EIP, and physically weaving it back and forth through the recipient tendon, the EPL stump, multiple times. Imagine threading a thick needle and yarn back and forth through a piece of fabric.
Why specifically a Pulvertaft weave, though? What are examiners looking for when they ask you to justify this technique over others?
They want two very specific biomechanical and surgical reasons. First, the weave creates an incredibly strong junction with a massive surface area for biological healing. Tendons need broad contact to heal solidly.
And the second reason?
Second, and practically more important for you in the operating room, the weave allows the surgeon to easily set and infinitely adjust the precise tension of the transferred tendon before sewing it permanently.
I've actually watched this in the OR, and tension really is everything in hand surgery.
Right.
You leave the tendon through, you pull it, and you watch the thumb rise up like it's attached to a puppet string. You can pull it a little tighter, test the thumb posture to see if it matches the other hand naturally, loosen it a bit if it's too tight. The weave holds the friction while you find that Goldilocks tension.
Exactly right. High strength and adjustable tension. Let's synthesize this scenario for the exams.
Here are the core facts to repeat. EPL ruptures are associated more commonly with non-displaced distal radius fractures due to silent ischemia.
EPL ruptures happen after non-displaced wrist fractures.
The reconstruction is an EIP to EPL tendon transfer.
The surgery is an EIP to EPL transfer.
The Pulvertaft weave is used for two reasons: to create a strong junction with high surface area and to allow for adjustable tension.
The Pulvertaft weave provides high strength and adjustable tension.
If you only remember one thing from this vignette, sudden loss of thumb extension weeks after a non-displaced distal radius fracture is an EPL rupture. Fix it with an EIP to EPL transfer using a Pulvertaft weave to set the exact tension.
Beautiful.
Moving on to our final topic before the lightning round. We are shifting from trauma to chronic inflammatory disease. Extensor rupture in rheumatoid arthritis, specifically a pattern known as Vaughan-Jackson syndrome.
Right. So a patient with a 10-year history of poorly controlled rheumatoid arthritis comes into your clinic. They hold up their hand and report that their fingers are spontaneously dropping. They can make a fist, but they cannot straighten their fingers at the main knuckle.
The crucial diagnostic question here is, which finger drops first, and in what direction across the hand does the pathology progress?
The first extensor tendon to rupture in the classic rheumatoid hand is almost always the extensor digiti minimi, the EDM in the fifth compartment, the extensor to the little finger.
And then what?
After the little finger drops, a few months later, the ring finger drops. Then the middle finger. The progression is invariably ulnar to radial, little finger moving toward the thumb.
This isn't just random bad luck, right? There is a brutal, relentless mechanical reason for this specific progression.
It is entirely mechanical. In severe rheumatoid arthritis, the synovium lining the joints becomes heavily inflamed and destructive. At the wrist, this synovitis frequently attacks and destroys the ligaments, stabilizing the distal radial ulnar joint, the DRUJ.
And without ligaments, the distal end of the ulna bone subluxes dorsally. It violently pops up at the back of the wrist, creating a prominent, jagged, roughened spike of bone under the skin.
We call this prominent spike the caput ulnae.
And think back to our wrist map. What sits right next to the caput ulnae? The EDM tendon in compartment 5.
Exactly. The extensor tendons are now forced to glide back and forth over this sharp, bony rock every single time the patient moves their fingers. Because the EDM is the most ulnar tendon, it is the first to rub against the caput ulnae.
It frays on the rock and eventually snaps.
As the disease progresses and the joint collapses further, the EDC tendon to the ring finger becomes the next one in line to hit the rock, so it frays and snaps. Then the middle finger. This highly specific pattern ulnar to radial extensor tendon rupture caused by attrition over a rough distal ulna is called Vaughan-Jackson syndrome.
This clinical picture raises a vital surgical question. This raises an important question. If you see a rheumatoid patient who has just dropped their little finger, what is your surgical imperative?
Your absolute imperative is that you must address the primary bony cause before you even look at the soft tissue. You cannot just go into the wrist and stitch or transfer a tendon.
Because if you reconstruct the EDM but leave that jagged spike of bone, the caput ulna sticking up,
your beautiful tendon repair will tear on the exact same rock within months, and the ring finger will inevitably follow. You must perform a procedure to remove or smooth out the distal ulna, like a Dirac procedure, which resects the distal ulna, or a Salveck-Kapanji procedure, and surgically clear away the inflammatory synovitis.
You must remove the rock, then reconstruct the rope. Let me synthesize this for the listener. Twice. In the rheumatoid hand, the EDM ruptures first.
The EDM ruptures first.
The progression of rupture is ulnar to radial.
The progression is ulnar to radial.
The mechanical cause is fraying over the rough caput ulnae.
The mechanical rock is the prominent caput ulna.
This exact pattern is called Vaughan-Jackson syndrome.
The eponym is Vaughan-Jackson syndrome.
If you only remember one thing from this segment, in rheumatoid arthritis, the EDM ruptures first and progresses ulnar to radial over the rough distal ulna. This is Vaughan-Jackson syndrome.
Got it.
All right, take a deep breath. Keep your eyes on the road. We are shifting gears. It is time for the lightning round. I'm going to fire off the ultimate rapid-fire exam questions covering everything we discussed, and we are going to deliver instant, precise answers based exactly on the source script. Ready?
I'm ready. Let's run it.
Contents of the first compartment.
APL and EPB.
Nerve in the fourth compartment.
Terminal branch of the posterior interosseous nerve, the pin, with the EDC and EIP.
Lister's tubercle sits between
Compartments 2 and 3. The EPL hooks around it.
central slip insertion.
Base of the middle phalanx.
Boutonnière posture.
PIP flexed. DIP hyperextended, caused by central slip rupture.
Swan-neck posture.
PIP hyperextended, DIT flexed.
What is not a cause of swan-neck?
Central slip rupture. That causes a boutonnière.
Mallet finger lesion.
Terminal extensor tendon tear at the DIP joint.
Boxer's knuckle.
Radial sagittal band rupture, causing ulnar subluxation of the extensor tendon.
Elson's test.
PIP flex 90 degrees, extend against resistance. A rigid DIP means central slip rupture.
Boys versus Elson.
Elson is for the acute tear, Boys is for the late and adherent tear.
Loss of thumb extension after a distal radius fracture.
EPL rupture, which is more common in non-displaced fractures.
Reconstruction for an EPL rupture.
EIP to EPL tendon transfer, using a Pulvertaft weave for strong, adjustable tension.
First extensor to rupture in rheumatoid arthritis.
EDM, progressing ulnar to radial. That is Vaughan-Jackson syndrome.
Boom. We have mapped the entire extensor mechanism, from the 6 tunnels of the wrist right down to the tiny lateral bands at the fingertip. We've deconstructed the biomechanical collapses, navigated the trauma traps, and hopefully saved a future patient from a missed central slip tear.
If you connect everything we've explored today, you realize how fascinating it is that the extensor web is so finely tuned, yet so profoundly vulnerable to silent downstream effects.
Right.
A failure at the tip eventually destroys the middle joint. A failure of a volar ligament destroys the dorsal web. It is a closed system of incredible delicacy.
And that leads me to a final thought I want to leave you with, something to ponder on the rest of your drive or as you finish your chores. Consider the profound paradox of the EPL rupture we discussed. As orthopedic surgeons, we are trained from day one to fear the violently displaced fractures, the mangled limbs. We inherently think that damage is always obvious and visually spectacular on an X-ray.
Right.
Yet it is the perfectly aligned, non-displaced fracture that silently swells inside an intact compartment, acting as a slow, ischemic tourniquet on the EPL over weeks. It makes you wonder how often the most seemingly stable, conservative treatments in medicine actually mask the highest risks of silent attritional damage.
It is a sobering reminder that biology operates underneath the X-ray, totally invisible to the naked eye until the mechanism snaps.
Next time, we are diving into Module 3. We are going under the skin to the intrinsic muscles and the 3 nerves that run the hand. We will be mapping Guillen's canal and unlocking the infamous ulnar paradox.
It is going to be a phenomenal session.
Keep replaying those deformities and bedside tests in your head. Visualize the boutonnière versus the swan-neck. Picture the wood-like DIP in Elson's test. Go absolutely crush your exam.
You have got this.
We'll see you on the next deep dive. Remember, the flexors might just be ropes pulling pulleys, but the extensors, they are a web in delicate, beautiful balance.